Hey, you guys, welcome back. Welcome back. All right, so I wanted to hit antibiotics as y'all requested, and I promised that I would cover that. We've been working through a few things from my review book, and I took some requests. Antibiotics is one of those things that I commonly get questions on. I've done a review on it, and you'll see some of my videos on antibiotics here as well. But I wanted to take a moment and kind of go over those with you. If you've taken any of my things or listened to my videos, when we talk about pharm, I like to tell you guys, I'm a firm believer with going over pharmacology with the system instead of creating a separate group of things to study. I feel like that just adds to the overwhelm factor. And then you learn it and then you try to associate it back to what you are studying. So, for example, if we're covering respiratory, we go through the meds based on the actual condition and the treatment. And if you are not familiar strong enough, like strongly with that actually drug class, then go back and study it as such then. But I don't mind doing antibiotics in this way because it does give you a moment to break them down into their actual drug class, learn the endings, the things that I always talk about, and studying those so that you're able to gear your mind when you get in those situations that you're trying to figure out which one is best. But still, as you review, please, please, please do yourself the favor and group it together by the system. Okay. So the antibiotics, like I tell you, always think assessment, diagnosis, evaluation, and treatment. So as we go through those systems, this is how we want to treat. So then you sit here and you think through. And commonly, one of the things that with like antibiotics, it's like, oh, they have an allergy to this. So then we went to that. Write those things out, that first line, that second line, and even if you need to, the third line therapy, so that you are able to get that into your mind and then think of those groups. Okay. But I think with antibiotics is very good to help you so you can think of like the contraindications, etc. Okay. So, I always like to give my disclaimer before I get into things any deeper. But for those of you who are new to me, welcome, 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 you guys. Those of you who have been here, seen my videos, done any of my review courses, and are familiar with me, welcome back. Hey, y'all. All right. But I like to always say, I do these videos to help nurses and nurse practitioners be successful on exams, boards, as well as in practice. I know things are, as far as guidelines, vary for the actual boards and what we may currently be doing as boards are working to catch up, because it takes a moment to design these boards. I say it all the time. So sometimes they might be slightly behind what we're currently doing. And so I will always tell you when we're doing what we do in practice is what I'm teaching on, or what we are the currently test is on. And I spoke on this recently about, what the ANCC has on it. Y'all go check out the blueprint. The last one was last year. I think it was September 2022 was our latest one with the ANCC. So ANCC is always 60% of the exam is non-clinical content. I stress that all the time to you guys, but it's telling you what they tell you what they're testing on. They tell you, what guidelines, like you just got to look at the content that, and I mean, I stay on top of this stuff so that you can know, and I don't want to get on the soapbox, but so sometimes it may seem like it varies, but that is why. But I always say to you guys that, hey, in medicine, there's no absolutes. We treat on a patient by patient basis, but I give you this information to help you in these formats. Okay. So let's get into the information. All right. So I just did a brief image here because it's so heavy when you think of antibiotics, and I don't like to do the overkill. I think it's just a lot. It just makes it overwhelming when we don't need any other uh overload. So with antibiotics, think one of the first things I like you to think of is bactericidal versus bacteriostatic, right? And so what does that mean? So I'm big on med term. If you get stuck and you don't have a clue, what's the med terminology saying to you, right? So thinking of bacteriostatic, static meaning like stay, their stasis, it's still. So bacteriostatic is making the bacteria stop, it's limiting that growth, it's making it stay in that place, like stop it in its tracks, so to speak. bacteriostatic. So it's limiting the growth of that bacteria, so it's not worsening. Whereas bactericidal, you think of cidal, what is that? What do you think about? Like homicidal, you're thinking of those things. Cidal, to kill, is killing the bacteria, right? So with the bactericidal antibiotic, those in that class are directly killing the bacteria. Bacteriostatic is stopping the growth of the bacteria, okay? All right. So first one, let's get into the tetracyclines. With all meds, I tell you guys, know your endings, okay? Know your endings. So when you get stuck, sometimes these are lengthy names and things, and you're like, look, we can't know all the medicines. They can come out yesterday, right? And we'll see the ads, and you're out here, and someone's asking you about it. Hey, but if you know the drug class, we know what this is, what it does, etc., right? And what we should not prescribe with, in conjunction to if it has a contraindication, etc. So I want you to know it for those purposes. So tetracycline, cycline is your ending. So think of like your doxycyclines and things of that nature. Now I say doxycycline because that's one of the most common ones we see, right? And so then I like you to kind of think about it, because this is what I mean when you're thinking of these as you're working with the actual system, because tetracyclines, we commonly hear it in like more severe acne treatment, not your mild but more severe, and then various other areas, right? So a lot of times, hey, the first line therapy may have been this and that didn't work, so we went to doxy, or they had an allergy to this, so then we utilized doxycycline, in some respiratory infections, in some STDs, STIs, so. But I'm just going to talk about it in the group, but I just want to kind of gear your mind where I'm going, right? But tetracycline is bacteriostatic. So tetracyclines work to stop that growth. So, stop it dead in its tracks, right? So that's the way that is actually um working. But some of those things that with tetracyclines that you want to make sure, we don't give tetracyclines to pregnant women. We don't give it to children under 9. And for these purposes, because, and then I'll get into some of the other side effects, adverse reaction type things, but we don't give it to our pregnant women because it can cause like bone deformities, like limiting the bone growth and issues of that nature. So you don't want to give them that as the pregnant woman is developing a baby, right? And also, you don't want to give it to children under the age of 9 because it can cause discoloration of their teeth, like very distinct discoloration, like brown discoloration of their teeth. Um, and then, as we talk about it, it can cause photosensitivity and things of that nature. So, you want to inform your patient of these things that may occur while they're on these medications, and then you to know that you're not giving these medications to those population. So the main thing is avoiding the kiddos 9 and below. So even if you're pregnant, you don't even want to give it to them because it can affect the growing child in utero, right? Um, and I'm trying to think what else I wanted to go over with tetracycline. That's the gist of tetracyclines, right? So bacteriostatic, right? So it's stopping the bacteria in its tracks, ends in cyclines. We don't give it to our pregnant women because it can cause bone defects. We don't want to give it to children under the age of 9 due to discoloration of the teeth that it can cause. It may cause photosensitivity. Explain it to the patient. Um, so they can wear sunglasses, various things to help and aid as they are taking this medication. And then just trying to educate them on limiting their exposure to the sunlight. Because it can cause some sunburning and skin damage from that due to the extreme sensitivity. Making sure that they're flushing everything when they're taking those medications, getting a full glass of water, etc. All the things with tetracycline, right? All right. Next, let's get into the penicillins. Now, penicillins is a very common drug class. Our cillins, ending the cillins, they're bactericidal, so you know that they work to straight kill the bacteria, right? So they're killing those. So we think of all of them, the penicillin, the amoxicillin, all of the cillins, right? Um, I say with penicillins, really be familiar with the history of any allergies. Well, and truthfully, with any medication and antibiotics, but penicillin is a common one that people may have allergies with. Also, as we talk about antibiotics, you always want them to have food on their stomach because antibiotics can be pretty harsh on the GI system, but the penicillins are one of the common ones that really you hear more complaints and adverse reactions to that GI system. So you want to make sure to let them know eat because they can have stomach cramps, they can have heavy diarrhea, um, etc. Okay. Now, again, so penicillins, indoncillin, review for allergies. They are bactericidal. There are forms of the broad spectrum where they cover vast of the gram positive and gram negative uh, bacteria, the different groups. Another another thing I like to say when I talked about penicillins being so heavy um, on the GI tract, also you'll commonly hear of you hear this with a lot of antibiotics, but females complaining of like yeast infection, Canada, and so just implementing those factors beforehand, just in case. You can ask them if they potentially have a history with this. But penicillins are one of those medicines. So if you're considering doing other meds like diflucan or promoting probiotics and the yogurts and things of that nature, that's one of those antibiotics you want to do that. And penicillins are also a part of the beta lactam group, as well as our cephalosporins. So cephalosporins are bactericidal, just like our penicillins, because beta lactams are. They're both in that category. But the thing that gets people so hung up with cephalosporins because cephalosporins have so many classes. Like there's so many of them. There's about five. Yeah, there's five generations of the cephalosporins, and so it can be confusing from all of the different tiers, but when you see the ceph in the word, you know it's a cephalosporin, right? Your ceftriaxones, etc., things like that, right? Your rocephin, your ceftin, all of the things. When you see that, know that it is in here. Now, where the generations come into play, it's more so along the lines of how it affects and how it works from the bacteria standpoint. You know what I mean? So like as far as on a broad spectrum range, I guess is the word I'm trying to say. Um Trying to find an easy way to explain that because I've already told you that they're bactericidal, right? So they're killing this, but broad spectrum can affect the gram positive as well as the gram negative. It's it's treating on a broad range, but then there's some of the classes that more so focus against like just the gram positive bacteria. So that's where the various generations come into play. And one of the main things I want y'all to remember when you think about penicillin, when we're thinking about allergies, penicillin and cephalosporins, I link them together almost like we do chlamydia and gonorrhea. I associate these two together. If somebody has that true penicillin allergy, you need to go ahead and assume that they're allergic to cephalosporins as well, okay? So let me just run back through that. So starting from the top, tetracyclines, right? Cycline. They are bacteriostatic, so they're going to limit that growth, stopping it in its tracks. We don't want to give that to the kiddos, our pregnant women. And when I say kiddos, none of them under the age of 9, right? They can cause photosensitivity, the discoloration of teeth in children. That's why we don't want to give it to them under the age of 9. And it can cause bone deformity. deformities, and that's why we're not giving it to those pregnant women as well. Okay. Penicillins, indencillin are bactericidal, a part of the beta lactam group. Um, can be very heavy on the GI system. So making sure that they have food on their stomach when they're taking these can cause candida. So you want to make sure that for those, especially women who have a history of this, ask that so that you can treat this, but make sure that you're advising them on the things that they can do to be proactive on the prevention of having that vaginitis or Candida associated with it, right? Also, cephalosporins. There are the 5 generations, like I spoke of. We commonly deal with the first 3. I was telling you guys that it's broken down in that way based off of how its coverage. So there's broad spectrum. Second generation is the only one that's broad spectrum out of those 3. The first 3 generations, 1 and 3, are um, for gram positive. They affect the gram positive ones. And also with the cephalosporins, if the person has a true penicillin allergy, we will treat and operate as they have a cephalosporin allergy. Okay. All right. So fluoroquinolones. These are also bactericidal, so that means they work to kill the bacteria. They those are our ones that end in quinolone, right? The quinolone family. And I said you'll see them in the fluoxetine. So I said they end in quinolone. They end in fluoxetine, like your levofloxacin, your ciprofloxacin. They're in the quinolone, fluoroquinolone family. Um, they have broad spectrum treatment, and these are a couple of those ones that you really got to pay attention to because they can cause tendon rupture, right? So that Achilles tendon. So you're supposed to educate them on not doing such heavy activities while taking this medication. This medication, those medicines, we commonly see this like for respiratory treatment and things of that nature, like your pneumonias that are more severe. But I think of it because these are older medications, but the older population is who you see more so. I should say the adult population. And what I mean by that, because you don't want to give this to the children, and I mean anybody 18 and younger, you really don't want to give this. It's a highly contraindicated, and we still do it on a patient by patient basis, but that's a heavy contraindication. And thinking about that because a huge issue is that Achilles tendon rupture, and the younger kids are commonly active and things of that nature. But anyhow, again, let's start from the top. Fluoroquinolones is the quinolone family, ends in floxacin, like levofloxacin, ciprofloxacin, right? It's bactericidal, killing the bacteria. It is broad spectrum, meaning it works on gram positive as well as gram negative. Commonly utilized on respiratory infections. It can be utilized on UTIs and things of that nature as well, but more commonly on those, the respiratory stuff. And lastly, with the quinolones, I always say think Q for quinolones, Q for QT interval, because you do not want to use these medicines with those cardiac drugs like your amiodarone, things of that nature, because it can prolong that QT interval. QT interval, okay? So if they're taking amiodarone, if they're on antidepressants like your tricyclics, those TCAs, you don't want to give it with that. Um, as it can directly affect cardiac wise and prolong that QT interval. Okay. All right. Next, we have our sulfonamides, commonly known as those sulfamides. They are bacteriostatic, meaning that they limit the growth of that bacteria, making it stop right in its tracks, right? Commonly against those gram negative um, bacteria, not to give in those who have a sulfur allergy. Also, you want to consider with medications, you don't want to give with patients who are taking Coumadin. You also want to be careful with patients um, that are pregnant, right? We don't give sulfur meds to our pregnant population, people who have the allergy. And like I said, really commonly, one of the common medications is the Coumadin. It causes more bleeding, right? So you want to pay attention to those. And then next we have macrolides. Yeah, I keep kind of look and make sure that I am covering all of them. So we did tetracyclines, penicillins, cephalosporins, fluoroquinolones, sulfonamides, and then our macrolides, right? And so our macrolides. I don't know why I like macrolides. Uh, that's the drug class that they're bacteriostatic, halting that bacteria growth, right? Stopping it in its tracks, limiting the growth of the bacteria. They end in myosin. They commonly treat that gram-positive bacteria group, but those are your myosin, your erythromycin, your azithromycin, things in that group. I don't know why I've always just like that. That's weird, but I do for some reason. Um, this is another one of those medications that can cause GI upset. So make sure they have food on their stomach, because and let them know, because it can cause severe diarrhea. They may become nauseated, things of that nature. And also, just knowing that this can prolong that QT interval as well. What's the other one that I just talked about that can cause prolongation of the QT interval? Fluoroquinolones, right? Q for quinolones, um, Q for QT interval, right? And this can also cause ototoxicity. So I want to go from the top, kind of ask you a few of these so that you can kind of get it in your mind. So is tetracycline bacteriostatic or bactericidal? Bacteriostatic, right? Stop the cycle right in its tracks, right? Is which two can cause QT prolongation? Is it tetracycline, penicillins, cephalosporins, fluoroquinolones, sulfonamides, or macrolides? Put it in the comments. Tell me what you think. So, what do you think? Should be fluoroquinolones and our macrolides, right? Um, if if a patient has a true severe penicillin allergy, which other antibiotic drug class should you begin to assume that they have an allergy with as well? Tell me what you got in the comments. Cephalosporins. All right, let me grab my review book and see. Let's see if I can just find a random question with a antibiotic as a treatment so that you can think through, because I want to kind of give you the idea of what I mean by studying with the system. Because, all right, boom, I just turned right here. Let's see what this is talking about. A patient presents to the office with complaints of a rash that will not improve. The nurse practitioner assesses the patient and notes a rash to the palm of the patient's hand and the soles of their feet. Based on these findings, what would be the best treatment? Is it A, clindamycin, B, doxycycline, C, penicillin G, or D, flagyl? Tell me what you think in the comments. I'll give you a second. And this one, it should be C, penicillin G, right? Because that presentation is like style for syphilis, but that wasn't one that I wanted you wanted you to think about. I just saw antibiotics. Hold on. Let me try to find a different one. Hold on. I'm just flipping through. Trying to find one that's gonna make y'all think on the lines of, to make you think through some antibiotic things, right? And as I flip through, y'all tell me if y'all have specific questions on anything, if you want me to go over something, if you need me to go even deeper with this, y'all know how I am. I don't like to go too heavy. Even with my review book, I have it broken down real short and sweet and to the point. So if you need more, let me know as well because I have videos associated with things also. Now watch. If I wasn't recording, I would be able to find a good one quickly. All right, let's try this one. A A 67-year-old male presents to the office complaining of chest pain and a fever while driving home. He states that while at the grocery store, he suddenly felt ill. The patient states that he cannot quit coughing up this brownish sputum. The nurse practitioner assesses the patient and notes his blood pressure is 86/60. What is the best treatment option for this patient? Is it A, azithromycin, B, doxycycline, C, levofloxacin, or D, amoxicillin? Tell me what you think in the comments. What you think? What you think? Is it A, azithromycin, B, doxycycline, C, levofloxacin, or D, amoxicillin? Let me see if I saw anything else. So the best answer is C, levofloxacin, right? So let's go back. Let me slow you down. So I always tell you guys when doing a practice, doing any questions, read the stem of the question first, right? So that you can slow yourself down and ensure that you're answering what they are truly asking of you. So the stem of the question states, "What is the best treatment option for this patient?" So then you want to start seeing what they have going on, right? 67-year-old male comes to the office complaining of chest pain and a fever while driving home. States that he was at the grocery store and he began to feel ill all of a sudden. He can't quit coughing up this brownish sputum. These are classic, for community acquired pneumonia, right? That brownish sputum that he can't quit coughing up, I talk about like those key descriptions, those descriptive terms. That is a key description right there. That like I like to say, when I say this, you think that. If I say brownish sputum, you should think community acquired pneumonia. And in my like reviews, I talk about my Brittany's brilliance, and y'all, I just say Brittany's brilliance is my term that I use for my craziness that comes to my mind when I think of these things. But I say, community acquired pneumonia is cap, so brown cap, right? You throw on your cap because you had to suddenly run out the house to do something, right? You threw your cap on your head, your brown cap. So brownish sputum, community acquired pneumonia, it happens suddenly, right? You suddenly have these symptoms, and so it's typically when they their presentation they'll come to you and they're saying, "Hey, I was doing this and I was feeling fine. And all of a sudden, this just came down on me. I was seeing this brownish sputum, etc." Right? So now that you know, or you're thinking that your differential diagnosis is that community acquired pneumonia, you want to start breaking this down because it's asking you what you want to treat with, right? And I'm always telling you assessment, diagnosis, evaluation, and treatment. So your assessment, the patient has come in here, he's 67 years old, he has sudden symptoms, he's having chest pain, he has a fever, he has brownish sputum. You're thinking your differential is community acquired pneumonia. What do you do next? Our gold standard is that chest x-ray to confirm it, but the question here is asking for the treatment, right? And so now you're going to break it down from the standpoint of um, what group to put him in, right? So you're thinking of the curve 65, of his severity. You're looking at his age. You would typically ask if he's been on any antibiotics in the past 90 days. But in this juncture, levofloxacin will be the best because one, in that 67-year-old age bracket and the severity, you pull out the big guns for them because pneumonia is common to be a fatal issue in the older population. So your best answer here would be C, levofloxacin. You want to go with your respiratory fluoroquinolone. But when I say this, I want you to think. So when we think about those medicines, what if they would have told you that this patient takes Coumadin, or what if they said this patient has a history of cardiac arrhythmias? You definitely wouldn't want to give that, right? Because it can cause QT interval prolongation, right? So those are the type of things that I'm saying that I like to just give you that feedback when we do like the antibiotics broken down, just in case they throw that in the scenario. But also to give you the mindset of the reason that I say study by system, because when you're testing, this is how they are going to design and give you those questions. It's going to go what is more so directed to your treatment option, right? But yeah, I think that's the best one that I can give you just quickly. But all right, you guys, I hope you found this helpful. If we did a quick recap, remembering bactericidal versus bacterial static, cytal is killing the bacteria, whereas bacterial static is stopping it in its track to limit the growth of the bacteria. Remember looking at your endings, tetracyclines ending cycline, penicillins ending cillin. Those cephalosporins have the word ceph in it in some formation in those 5 generations. We commonly focus on the first 3 generations. Fluoroquinolones in the quinolone family end in fluoxacin. Your sulfonamides have sulfa, the word sulfa in it, and your macrolides are your myosins, right? When you think about applying this information, I want you to think about any drug to drug interactions, contraindication, and things that you need to be able to tell your patients to prevent any adverse reactions or to prepare them for something that is commonly seen with these. Um, Thinking about allergies with these and when to give and not to give, or what things to look out for. And then just breaking it down as you're studying for each actual condition that this would be a treatment option for, and look at those first, second, and third line therapies. Okay. All right. If you have more questions, y'all know, feel free to let me know so that I can go over these. I think that y'all receive the videos better because we can kind of walk through these. So I'm happy to do these. So please feel free. Y'all, we're about to head into an entirely different month. I mean, this year is flying by, but let me know. I'm happy to cover it. And as always, you guys, thank you for watching. But be sure to like, comment, subscribe, and share with whomever you may think may find this beneficial as well. Feel free, if you need me, to reach out. You can reach out via phone 803-400-6864, or shoot me an email at thenursingstudio1@gmail.com. Yes, I do offer one-on-one sessions. That's been the most recent questions. I do that, and we do have review courses. I will release the upcoming review courses. That will be in about 2 months. But I always have my online sessions available that you can do self-paced, and you can also do the self-paced with me included for your weekly one-on-ones in the review course as well. But as always, meet me back here. Bye, y'all.